A bloodless medicine or a transfusion-free medicine and surgery program, in my opinion, I think many of my colleagues, is a program that has to be well-tuned, well-oiled, well-organized. And I think the structure being interdisciplinary and interdepartmental is very key. And so not to go through all the departments, but you see the list of departments almost from A to Z is quite important in the collaboration. Any program, as I understand it, that truly has a good structure would have an operating policy, usually a clinical practice policy of some sort that would govern how patients are treated, the purpose of having this program and the ideology surrounding how Jehovah's Witnesses or other patients who refuse blood are treated, and of course, what should be done. The key to any structure and organization, of course, is to make sure that we're not all over the place, not trying to figure out what we're doing, that it's something that's, again, well-tuned. And so this is something that my little corny saying, line of the Asians, to me, it's about identification, documentation, communication, cooperation, and collaboration. Maybe there are a few other Asians that we can include in this. And so in regards to identification, in our center, as no doubt other centers, we use Cerner as far as our EMR, and to identify that the patient does not want a blood transfusion. So you see here that we have in our, this appears on a banner bar that in green, if medically necessary, would you consent to blood or blood products? Yes or no. We have request more information, that's going away. Really, it's yes or no. As one of our blood bank technicians used to say, either the person is pregnant or they're not pregnant, or either you want blood or you don't want blood. So it's something that we feel is key. Documentation in terms of having a blood refusal. Some centers may or may not use a form that will document a patient's wishes. Of course, Jehovah's Witness patients will have their advance directive. So this is key to have documentation about clearly their wishes, what they want and what they don't want. Further documentation, I feel, of no blood products armband. Something that seems simple, but I think whenever any provider, practitioner is meeting with the patient, dealing with the patient, to make sure as you're checking date of birth and name and medical record, make sure you're checking that as well. And then having a form that will itemize. I appreciate Dr. Cuzon's talk and all the talks earlier. I was on, I think, Monday and Wednesday. I missed yesterday. But in terms of the different strategies that are used, so I think this is a key for communication too. And at our center, our surgeons especially look for this. Even if the patient has an advanced healthcare directive, oftentimes, as many of my colleagues will say, it's not as clear, not as specific. And so we look for something that will delineate the different products, treatments, and procedures that can be used. To me, this is a very key document, or at least some sort of understanding, communication about what the patient will allow for, especially, of course, Jehovah's Witnesses. And then more documentation, communication, identification, you can say here. We started using a color-coded chart binder about 10 years ago after a near miss event, and it had to do with a patient who was hypotensive post-op, and immediately post-op sent to the ICU. The chart was there, but it was not, they didn't pay attention to it, the nurse, and so delivered a product, not blood, but albumin. The patient didn't want albumin. And so this is another key aspect we feel. So I know I have a few more minutes. Wrapping up, in terms of the administration and patient care management, I'm not a clinician. I am an administrator for the hospital. I've been at USC since '97 and started in this field a year before. But a lot of aspects, one thing is, how do we get patients into the hospital? We are primarily an elective surgical hospital, although we have many patients transferred with hemoglobins, perhaps in the 3s and 4s and so forth. And so facilitating outside hospital transfers is key. Making sure that from top to bottom, we are educating our staff whenever the patient comes in about the appropriate management. And this is a little bit about how the referrals will flow. I'll skip this because in our experience, I think, as I believe was mentioned, that Yvette works with the quality department. So I report to our chief medical officer, who oversees quality, infection control, environment of care, and so forth. And so we have a very serious quality goal to make sure patients are managed according to our policy. Why have a policy? Why communicate? Why identify, why educate if you're not following it? So in our safety risk management system, we are quite vigorous in reporting any fallouts or near fallouts. Also, a feedback report has to do with the physicians. Are they being culturally sensitive, appropriate in managing the Jehovah's Witness patient, especially who does not want blood? And this is taken seriously. So our goal is, we'd like to say 100%, but at least to make sure that 95% of our patients are, excuse me, managed per policy. Finally, achieving improved outcomes. I believe that having a structured, formalized program does heighten awareness, of course, of all staff. We avoid delays in receiving the necessary treatment, medical or surgical. This is, to me, key, reducing patient anxiety. As again, many of my colleagues will say, many patients, Jehovah's Witnesses especially, the goal is to not just promise not to give blood, but to have competent, supportive physicians, nurses, and so forth to deliver that care, improving cooperation with the physicians, and of course, enhancing cultural sensitivity.
So when we talk about optimizing the hematocrit, it's very important to intervene very early to try to correct the anemia. So then we're going to consider what hematinic agent are we going to use? What iron preparation will we be using? Will we be using oral versus intravenous iron? I will say that we tend to use more IV iron because the response time is generally quicker. But again, I understand that based on a person's economics or what they have available to them, they may need oral. So these, you see the most common preparations listed here, and also to reevaluate the use of erythropoietin and use that when it's appropriate. We may also combine that with some other adjunct therapy, vitamin C, folic acid, vitamin B12. And of course, too, we look at also providing nutritional support or counseling to the patients to help them to understand what can they also supplement in their diet to enhance, correct their anemia as well. What you see on the slide now is an example of 2 algorithms. We're currently working with our cardiac surgery program because we know that anemia is not something benign, but should really be addressed at all times. So we have on the left an algorithm to address inpatient preoperative anemia management. Some people feel you can't do anything, but we feel it's important to do something. So we do initially start with some iron and erythropoietin. And then on the right side, you see our outpatient algorithm. And the takeaway point from that is we try to do it, and we can do it and have done it successfully in 2 weeks. We would prefer 3 if we could get that. But again, to make it a seamless process for the practitioner and to minimally interrupt their normal flow. We want this incorporated into their flow of patient care. Minimizing blood loss. On my next pillar, a careful assessment for bleeding risk has to be done. So that will include a history of any bleeding disorders. Is the patient on any anticoagulant therapy? They taking any herbs that could perhaps impact their coagulation status. Careful operative and anesthesia planning is necessary. Some of the speakers to follow me will go in more depth about some of these techniques that are used, but just to list them: hemodilution, cell savers, what laser or scalpels would they use. Of course, a minimally invasive approach would cause less bleeding. So are we going to use something laparoscopic, robotic? Interventional radiology has also been referred to many times during this week. And of course, if we have a nice hemoglobin, it's to no avail if the technician, the surgeon, is not very careful and meticulous in their techniques, and as well as maintaining hemostasis, use of normothermia, anesthesias involved, whether it's going to be regional, general, also use of controlled hypotensive anesthesia, and then how we position the patient. Of course, we also want to consider what can we do to limit iatrogenic blood loss. So the idea of these endless ongoing serial blood draws, we should really eliminate those. The use of low fill or low volume soft draw vacutainers, microsampling where possible, VAMP or safe set systems, primarily systems that are closed systems when we're drawing off blood. Instead of throwing away the waste, we're able to reinfuse that to the patient, and of course, use a point of care testing. And then some pharmacologic management, whether it's vitamin C, TXA, Amicar, and you see others listed there well. the things that can also be used to attack bleeding on a systemic level. Dr. Danny did an excellent job also earlier talking about the physiology behind tissue oxygenation. But again, looking at volume replacement, and we're doing that to also kind of, in these patients that are severely anemic, circulate their remaining red cells and decrease the viscosity of the blood to increase cardiac output. Earlier this week too, we heard Dr. Kelly talk about, Amber Johnson talk about the use of oxygen therapy. So optimizing ventilation, of course, sometimes we do have to intubate patients, and even the use of hyperbaric oxygen. Minimizing oxygen consumption, treat their pain, use analgesics. Sometimes we do have to sedate these patients, mechanically breathe for them, keeping them normothermic, and use of beta blockers, and also treatment and prevention of infections. We don't want them septic. And then this whole category of artificial oxygen carriers, or otherwise known as hemoglobin-based oxygen carriers. In the United States, there are none that are currently FDA approved. They remain to be largely experimental, and you can sometimes get them on what we call a compassionate use. When we talk about the last one, lowering the threshold, the transfusion trigger or tolerance of anemia, this whole 1030 rule, how did that get born, came out of a study from Adams and Lundy back in 1942, where they decided that this was the optimal hemoglobin and hematocrit for surgical patients. And to date, that has certainly never been proven. It's kind of been accepted as gospel or law. But we've seen almost in the past 20 years, many randomized clinical trials that suggest a restrictive or lower transfusion trigger is more advantageous actually than these liberal transfusion thresholds. And the bottom line is really there is no universal transfusion trigger. Our minds really should be focused on treating the patient in totality, not just the number, but really looking at the patient clinically, totally assessing them, are they symptomatic? And of course, minimizing the blood draws. So for doctors or practitioners who feel they need to see what the hemoglobin level is, these are just some examples of some point of care testing that could be employed. And then really to keep in mind, if the test results are not going to change your plan of care, don't order the test. And since we're talking about bloodless patients, blood is not an option for them. So at all costs, we need to do all we can to keep the patient's blood in their body.
What I feel are the most important, some of the things we're doing that are helpful here at Georgetown, some of the things I'm going to talk about where I think we could do a better job of, and maybe some of these you do a good job of, some of them you don't. But really the bullseye over here, I think what has been the most effective intervention for our witness patients here, and I'm sure all around the world, is now using minimally invasive surgery, robotic surgery. That has really revolutionized and really been unbelievable for the witness patient. When I first got here and we were doing Whipple surgeries, we had a lot of pushback from some surgeons on they would not do our witnesses. And now this has become a minimally invasive technique, and we hardly ever use blood products with any of our patients in Whipple surgeries or liver sections or anything like that. So it's really been it's helped our bloodless medicine and surgery program, especially in robotics too. Surgeries such as hysterectomies, which were very bloody, now people go home the same day sometimes. And certainly with prostatectomies and a lot of surgeries. I keep the data for all of our program, for our patient blood management program. And I can tell you our patients who come in and are donating kidneys, for the past 2 years, not one patient has been transfused when nephrectomies were considered very, very bloody surgeries. So it's amazing what minimally invasive surgery, robotic surgery, stage surgery, all of these, and having an experienced team is so beneficial for our witness patients. Up top, I'm going to talk more about transexamic acid, but I think this is the star for us here at Georgetown. It has really revolutionized especially our orthopedic program, and I'll talk more about that in a little bit. I give a big clap to cell salvage. I think it's so beneficial for our witness patients. However, I think we don't use it enough for all of our patients. So we've been trying, I work with our perfusion team, and we've had an initiative for years trying to get more of our surgeons, in particular our multi-level spine surgeries, to use this much more. And I think some of the stuff that was presented yesterday, I think there's a lot of opening for different types of salvage of blood, the patient's blood, which I think in the future will be very, very beneficial, not only to our witness patients, but to all of our patients. Regarding acute normal volemic hemodilution, we really don't use that a lot here. We had one surgeon who loved using it. He used it on every single one of our witness patients that we sent him. But he has since retired, so we don't use it. We use it with our liver transplant patients, but that's usually for a different reason. Regional anesthesia, we use that a lot, especially in orthopedics. So it's become very prominent. And we use a lot of topical adhesives. So I think things like fibrin glue and Tisacil and those things have really, really been beneficial for our witness patients. So those are the main things I want to point out. I think where we miss the boat sometimes here at Georgetown is that I think we don't use point of care testing enough. And I would love to see something like HemaQ being used in the OR to look at pretty instantaneously, especially looking at hemoglobins, especially for our patient blood management program. Surgeons are quick to see that when a patient starts bleeding, they'll ask the anesthesiologist to give them a unit of blood, and we have no clue if that's even necessary. So I think point of care testing, I would like to see used more diligently here at our institution. I want to say one thing. I was so excited when the ERAS program started really becoming part of the program here at Georgetown. However, what I found out is part of the ERAS program should be pre-surgical anemia management. Unfortunately, it is not. And so we're trying to roll out to all our high-risk surgery cases, getting on board with that. And it's been a struggle. I work in our pre-surgical anemia management program. I work a lot with obstetrics and with our gynecological patients. So we really done a well job with there, but I'd like to see more rollout with our other patients when we can. Okay, so I want to talk about transexamic acid. One of the things what's really nice about transexamic acid, it's very inexpensive. It's widely used. It's been used in Europe long before we started using it here in the United States, especially with our orthopedic surgeons. And it's relatively low risk, okay? It has become a champion medication for our arthroplasty surgery. We really looked at this and we published some papers on this at MedStar Georgetown University Hospital from 2010 to 2015, before widespread use of transexamic acid. For primary total hip arthroplasty, total knee arthroplasty, transfusion rates were hovering around 20%, a little bit over, depending on the surgery. Now transfusion rates at our institution for total hip at 1.3%, and total knee, these are primary, 1.6%. So it's really done tremendous amount of benefit for our witness patients and all of our patients. Since 2015, no intraoperative red blood cell transfusions have been given for our total hip and total knee arthroplasty primary. We still see some for our revisions. And so it's really been a fantastic product, or a fantastic part of our minimizing blood loss. We type and cross we used to do for total hip and knee. We used to type and cross 2 units, and now we don't. That's been eliminated from our maximal surgery blood ordering schedule. The problem right now with transexamic acid, we don't know what the optimal dosing is. So that's not a problem, but an issue. It's unknown what the optimal dosing is. We use it a lot now with it's standard of care now with our postpartum hemorrhage protocol. So it's really being rolled out. We've rolled it out after seeing such great success with our orthopedic primary total hip and knee arthroplasty. We've rolled it out to our three or more spinal level fusions. We've rolled it out to our orthopedic surgeons and our neurosurgeons, and it's really been beneficial. So finally, we just published the role of arthroplasty in the Jehovah's Witness population. This was in the European Journal of Orthopedic Surgery and Traumatology. It came out in January of this year. And we looked at 184 patients self-identified as bloodless. 81 of those were primary and revision total hip arthroplasty, and 111 total knee arthroplasty. So I just wanted to give a shout out to transexamic acid. I think it's been really a fantastic way to minimize blood loss. And Dr. Johnson Arbor, my colleague, talked about the use of this in the ED for witness patients and really for all patients. So I think this is the star of minimizing blood loss for us here at MedStar Georgetown University Hospital.